Hi everybody, welcome back to our journal club. This is take 2. I'm just waiting for Dr. Andrea Kim to join us. It's funny because with the Women's Psychiatry Group and Psychiatry Network, she's actually in the women's group. So I just added her to Psychiatry Network and just waiting for her to join us. I'm gonna see if I can invite her. So tonight we're talking about ketamine. Which I was thinking is really funny timing because the FDA approval came out for the S-ketamine nasal spray for the indication of depression, and that was not planned that we're doing the journal club tonight, but I think I'm glad to be hearing about it because I know like some of our patients are asking about it, and I think we're all curious to see how this is going to play out in terms of like payments from insurance companies and things like that. So, yeah, how's everyone doing tonight? Hey, Sarah, how are you? If you're watching, feel free to say hi. Hi, Saba. I'm just waiting for Dr. Kim to join us, who on Facebook is Andrea K. Thomason. So I'm going to try and tag her. And all right. Oh, here we go. I think she's trying to join the video. All right. Hi, Khadija. Hey, Noreen. Hi. Hi there.
Hi.
Hey, how's it going? Good. Welcome.
Thank you.
I didn't realize you weren't in the group. So
Isn't that
yeah,
funny?
well, you know what? It's like there's so many physician and psychiatry Facebook groups that, like who can keep track, right? I think I'm in like,
I'm glad to be
I'm in
here.
like 20 different psychiatry themed Facebook groups. So yeah, well, welcome. And I was just saying that it's such a funny thing that the FDA, did it come out today or yesterday?
Like
Yeah,
yesterday.
so that we didn't plan that, but I think it's really good timing. So that's the topic for tonight. I'm sure lots of people will be watching because a lot of us don't know that much about ketamine. Okay, so I just wanted to read Dr. Kim's bio for everyone so that we know who is teaching us tonight. So Dr. Andrea Kim is a private practice psychiatrist in Dallas, Texas. She has a standard solo psychiatric practice as well as a ketamine infusion clinic, Texas Ketamine Specialists, that she owns with her partner anesthesiologist, Dr. Clark Morgan. Dr. Kim is originally from Houston, Texas, attended Harvard University for her undergraduate, and graduated magna cum laude with highest honors. She attended UT Southwestern Medical School for med school and psychiatry residency, where she was chief resident her final year. She's practiced psychiatry in the inpatient setting as well as her current outpatient clinic. She loves the deep and consistent relationships she's developed with her patients over the years and the time to ask questions and learn their stories better. She also loves the flexibility of private practice to pursue other passions, especially raising her 4 children ages 14 to 7. She's been a member of Psychiatry Network for a couple of years. I think maybe not, but maybe you have. And as a solo physician, loves.
So WPG is not Psychiatry Network.
Loves the camaraderie and fellowship and instant understanding that these Facebook pages provide. She loves especially to give a clinical consult to the hive mind during a patient appointment and get 5 great ideas instantly that she hasn't thought of before. I love that too, Andrea. So I didn't know that you have a ketamine infusion clinic. So that's great that you have that experience and that background in going over this article for tonight. So thanks for volunteering to do this article today. So feel free to get started.
Okay. So we're going to cover the consensus statement on the use of ketamine in the treatment of mood disorders by JAMA Psychiatry. This came out in 2017. And I jumped on this article because this was what got our ketamine clinic going as we went by this. So I'm pretty familiar with it. This is a review and a consensus article by the APA with a lot of caveats. It's not a endorsement, not to be construed as a standard or a guideline, that this is just basically what's the current state and what are critical things to decide. Because when they when they published this, a lot of ketamine clinics were starting to go, and they thought, well, we need to put out something so that psychiatrists aren't completely in the dark. So the authors, there are several. Santa Cora is the first author, and there's several more. Mark Fry, William McDonald, Sanjay Matthew, Mason Turner, Alan Schatzberg, Paul Summergrad, Charles Nemroff. The list of disclosures is immense. They're all the highlighted ones. They all have a lot of ties and speaking fees, grant support, including with Janssen, the S-ketamine people. They all have some ties to Janssen. So, well, not all of them, but definitely the first two. So I won't actually read all their disclosures because there's so many. So like I said, the introduction is really that they're just aiming to educate because people, infusion clinics are starting anyway, so they just want to educate people on what we know, what do the studies show, and this is on 7 studies with not a big number of patients that were positive that really all of a sudden got people going. And so they thought, okay, with these 7 studies that aren't that huge, what can we glean from, and what can we just comment on if you're going to do it? So, you know, you can interpret this article as how to do it, and you can interpret it as what we don't know. Mm-hmm. So I think it's useful. So for patient selection, this is on page 400, the second page. So they say in general, you would always consider somebody, this is mainly for depression, and it's major depression without psychosis. Obviously, we don't want to worsen psychosis. So they say you consider the severity of the depression, how long is the current episode, what is their treatment history like, and how urgent is this? So you make all these decisions together. And remember, the best data is for major depression without psychosis. Psychosis would actually exclude somebody in our clinic, because certainly we don't want to make the dissociative process worse for them. Then you do a thorough evaluation, which is, I think, critical in, and that would be on the table in the top right corner, 400. You do just like a standard psych eval and get their diagnosis, make sure that there's not an active substance use disorder, and they're not shopping for ketamine. And you would also get a thorough baseline. You assess their baseline, and this is key, I think, in our clinic, is you're always assessing to say whether things are working or not. You can do a quiz or a PHQ-9. The most important thing is that you do the same thing over time, so to see if it's working or not. You would get all the antidepressant use, best knowledge you can. And I'm going to go straight to the article only, so I'm not going to give too much practical, real world stuff of how we're doing. We can do that at the end, but I kind of want to just stick to the article. So you would get antidepressant use. You would do a review of systems, make sure that you're ruling out a few things that you need to rule out for ketamine. You would do a physical exam and lab screening as recommended by the cardiology, the American Heart Association, and the Society of Anesthesiologists. And then you would get whatever past medical and psych records that you can. You could get collaboration by family. Obviously, this is just all a really, really good psych eval. Make sure that there's no active substances, and a baseline UTOX. And then finally, number 7, the big one, you want to do a very good informed consent. We want to talk about the risks during treatment of ketamine itself, the limits of our knowledge with the 7 studies that we're basing all this on, potential benefits. This is off-label. I always talk about what's on-label for treatment-resistant depression, which is TMS and ECT. But ketamine is off-label. And then, the alternative treatment options. And then they need to express understanding and be able to get all their questions answered, and understand the limitations of some of their questions that I can't even answer. So that's patient selection. Clinical experience and training. So this is sort of the big one, is what do you need to be able to give ketamine? There's no actually guidelines for this, and I think it's almost state by state practically of what you need to do, because this is lower than anesthesia doses. So this is not really conscious sedation, licensure. It gets kind of tricky. At the dose that is recommended for ketamine, which is 0.5 milligrams per kilogram of body weight, There's no general anesthesia effects. So that's where the question comes in, is this conscious sedation or not? So there's no respiratory issues. They did study 833 people getting that dose level, and none of them needed respiratory assistance. Another study showed there was no change in oxygen sats. However, there can be hypertension, and that's pretty commonly seen as transient hypertension and increased heart rate during the actual infusion itself. In their studies, 30% of the study showed either an increase in blood pressure or an increase in heart rate. And the increase in blood pressure would be almost 20 points systolic and 13 points diastolic. So that is something that we take care of with. So basically, they say in this section, they do recommend an MD or a DO with ACLS training to be able to provide the treatments. And then finally, yeah, they dissociate. They can have behavioral changes. Psychiatrists can manage those, but psychiatrists need to be ready to manage those. We afterwards, before they go home, they get checked for suicidality, they get checked for safety, and they basically have a risk assessment before they go home. And then they need to follow up either with us or with their psychiatrist pretty rapidly. So the treatment setting is, they say be able to monitor and provide immediate care if needed, which is, makes sense. And then there's actually not a lot of evidence to support that they need anything specific monitoring. They just say you should be ready to do some basic monitoring, such as an EKG, check their blood pressure, of course, and then check their oxygen saturations, check their end-tidal CO2s. And of course, clinics have done this to different degrees. Be able to deliver oxygen, medication, restraints if needed, and then have a plan in providing ACLS or transferring to a hospital if you need to. The medication delivery, like I said, most of these studies have studied 0.5 milligrams per kilogram over 40 minutes. And they have shown that to be more effective than a low dose intranasal spray, which is interesting. That's racemic ketamine, not the S-ketamine. This came out like 2 years ago, but it's 50 milligrams of intranasal spray. And then they studied lower doses of ketamine. They really found that the most improved effect was at 0.5 milligrams per kilogram over 40 minutes. But they have a lot of caveats on how these studies were very different from each other and that we can't really draw conclusions. And so they say you do want to do some clinical judgment. So you don't go by, if it's a morbidly obese person, you don't actually go by their kilograms. You would go by their ideal body weight. Because at very high doses, obviously it's going to look more like ketamine abuse and actually get to conscious sedation levels, which we really don't want. So follow-up and assessments, we talk about, so what's the efficacy of short-term repeated administrations? And that's what the studies have really focused on. And by short, I mean short, like 1 month. They're seeing how long the effects last. So the data is limited, but one study would show that twice weekly for 2 weeks had a 69% response rate and a 37.5 remission rate compared to 15% and 7.7% of placebo. Although, as an aside, the placebo was midazolam. So people didn't really dissociate. And the question is, did you know that you didn't have ketamine and you got midazolam? And then 3 times weekly actually had a reduced response. So twice a week versus 3 times a week, this twice a week had a better response than the 3 times a week. So they say, twice weekly dosing is as efficacious, if not more, as 3 times a week for 4 weeks, up to 4 weeks. And then how to determine futility of treatment is a great question. This study would say there are a few reports reporting that people respond after 3 infusions. So then you would, the main takeaway is you keep using your instrument, your rating instrument, and just seeing if they're responding or not. And they know, actually, it's subjectively, these patients do know if they're improving. One study suggests that more ketamine does not help if the 0.5 milligrams per kilogram doesn't help. And of course, more studies are needed is the theme of this paper. and efficacy of longer-term repeated administrations. This is very limited data to the point where they can't recommend anything. What is happening practically, as they describe in the paper, is they're doing it 2 to 3 times a week for 2 to 3 weeks, and then they taper or they continue treatments based on how they're responding. But this is just what people are doing. There's not really data published on this. And of course, back to the table, the informed consent should include the risks of, hey, this is not a cure, this is management, this is going to be ongoing. We don't know what it looks like ongoing, in 5 years. We don't. So what is the longer term exposure? There's a lot of lack of data on that. So the safety measures in the continuation of treatment. So there are a couple studies that show that chronic high frequency abuse levels of ketamine can create cognitive impairment and interstitial cystitis, so bladder wall infections. Plus the abuse liability of the drug. You just want to keep giving periodic assessments of these things, check their cognition, check their like a bladder pain scale. They have those, and try to be vigilant about if they're doctor shopping for ketamine, which is hard because there's not a registry right now. And then you want to watch out with ketamine use disorder with a UTOX. We do UTOXs every infusion, every time, and a pregnancy test every infusion, every time, if appropriate. But you do want to watch it, get a UTOX, and then treat the least necessary to achieve a response. Do not send it home, which some clinics do, actually. And then discontinue it. This paper recommends discontinuing it if the dosing cannot be spaced to a minimum of 1 dose a week by the 2nd month. So by the 8th week, if you can't get it down to once a week, then it's just too much ketamine. They say this is not a feasible option for you. And then right now, this paper would say the whole goal is to get them stabilized and then taper. You don't want to actually keep them on this ongoing thing for a long time until more safety data can be collected. And so for future directions, they need more standardized clinical trials. I can think of 50 questions that could all be used as studies. And then a coordinated registry database would be great, because then we can all start monitoring, does it work? How well does it work? What does your protocol look like? What is it? So all that, we don't know. So that's the study. Yeah, go ahead.
Oh, no, I was just clearing my throat. Thanks for that. Yeah, I don't know if anybody has any questions. If you're watching, feel free to either about the study or it sounds like Dr. Kim's. How long has your clinic been doing the infusions?
Yeah, so we opened in September of 2017.
Okay.
So about a year and a half. Oh. We've done about 1,500 infusions now.
Oh, wow. Now. Okay. Yeah. And so I guess, I have lots of questions, if you don't mind.
Yeah.
So
sure.
What's the average, is this kind of an ongoing treatment at some point for somebody, or or do you kind of taper off and switch to some other type of treatment? What's the typical kind of course for someone?
Typically, and we're not talking about the paper anymore. Right. This is all practical, real life stuff. Typically, we have people who have been on 15 to 20 antidepressants.
Right.
Who have tried ECT. Yeah. I mean, they don't even have a psychiatrist anymore. They are so fed up with it. So ketamine for them is a game changer. I always try to get, in fact, we're now to the point where you must be with a psychiatrist. And so we try to work with a psychiatrist to get them stabilized, but then encourage them to try medications again. And so yes, we have people coming in for boosters now for a year. They come in on average, it's every 8 weeks. They need to come in for 1 booster. Okay. But that kind of varies too. We have people who have never come back. Oh. I don't know why they're so good, but I check on them and they're like, no, I'm still good. I'm off my meds and I'm doing great. So, great. But that's rare. That's rare.
And I'm just curious, is insurance paying for any of this, or is this people are paying out of pocket? Okay.
People are out of pocket. There is some creative billing that I haven't mastered, but
yeah. And so is this the only thing that you're doing, clinically? Oh.
No. I have my regular
but it's practice. A separate clinic from.
Yes, it's the same location. And I will, so really my clinic will do, I'll see patients all day, and then I'll see ketamine evals in the same clinic, and then 3 other offices in my suite are actually administering it with Dr. Morgan.
I see.
So I don't see them every single infusion, but I'll see them before and I'll see them after the 6th infusion, and then we look at their charts and stuff together.
We do have one question from one of our members, Lexi Nicole. Is there any data about how many patients remain improved or in remission at 1 year?
No, there is not, which is a great question. So I wish there was.
Yeah.
I was thinking really with S-ketamine, it would help give a lot of safety data, and I'm looking forward to seeing all their data. But no.
And S-ketamine is just the racemar of ketamine? Is it?
Yeah, it's the S isomer of racemic ketamine. It's actually shown to be less effective than racemic ketamine. And then there is a study, I believe, that R-ketamine, which is the other isomer, is some study, I think I'm hearing conflicting reports. Some studies say it's better than S-ketamine and some say it's worse. So, but someone has patented R-ketamine too. Okay. So stay tuned, you know, we'll see.
I feel like a lot of stuff is happening. And so I guess if somebody's interested in incorporating ketamine infusions into their practice, what kind of advice would you give them?
So I would say there are clinics everywhere. I'm partial to ones that have a psychiatrist on board. There are a lot that are just anesthesiologists running them, and they, you know, will provide the service, but really send that patient back to you, which I guess, I mean, everything's legal. It's just, I like the psychiatrist on board. Look for a clinic who's collaborative and will keep you updated. I guess it's hard to know. I feel like it's almost the Wild West out there. Like there's people who's going to infuse anyone over the phone. They'll approve you and get you in. And then there's people who make you jump through a lot of hoops. So I think just sort of interviewing some of the clinic owners and seeing how they do it is probably the best way to go. I would tell your patient kind of what this paper says is we don't know how long the effects last. We don't know if you're coming in every 8 weeks for 2 years. Are you going to need to start coming in every 7 weeks and every 6 weeks? Like, we don't know that. So there's a lot that we don't know. And I'm just a little more holistic anyway. So part of my informed consent is you got to do all the other stuff too. Like ketamine is going to get you out of bed, but then you got to incorporate all the lifestyle measures and that kind of thing.
But it sounds like it's really given some people who had trouble getting any treatments, like kind of getting them started. So that's great.
For sure. Yeah.
I'm trying to think if anybody else has any questions, feel free. You can always post comments and we'll try to get Dr. Kim to answer them in the next day or two. And for those of you who don't know about the Journal Club and how it works, I have the directions at the top of the post. You can watch this video anytime if you didn't get a chance to watch the whole thing and claim your CME. You have 12 months once you sign up through the American Physician Institute to get the CME. And by the way, we did post another new blog article tonight by Dr. My pronunciation of her name is like not the best, so I'm gonna just pull it up and make sure I'm saying it correctly. But she wrote an article on the neurology article that came out a couple weeks ago that was a little bit racist and sexist. It was Dr. Nowet. I don't have it in front of me. I'm sorry. I'm like butchering her name. So it's Dr. Naduki, is I think how you say it. So, but that's on psychiatrynetwork.com. Just go to blog, and if anyone's interested in a submission, feel free to put one in. So, all right. Thanks, Dr. Kim, for joining us and for that great article.
Thanks for having me.
Thanks. And yeah, we've got some comments just thanking you as well. So, all right. Have a good night, everybody.
Wonderful.
And thank you again. Take care. Bye.